listening to. Joel Zivot, welcome to the Kat and Coca Report.
Thank you for having me.
Great to have you, Joel. I discovered your writings and the work that you've done on a blog by an anti-euthanasia blog hosted by somebody in Canada. I mean, I don't know him except that I follow him, and he has insightful articles, and he mentioned something about you. And it's I jump on the occasion when I find somebody that's on the same page as I am on some of these issues. And especially that, you've made some empirical observations. I'm very good about the principles and the theory and whatnot, but I always like when physicians make some empirical observations that others haven't made. So we'll get to that, but let's start with you. You're at Emory University. You're a professor of anesthesia.
That's right.
Okay.
I'm a anesthesiology and surgery. I'm an anesthesiologist.
Okay.
And I also practice critical care here. I have an appointment in the law school, and I also teach undergraduates. So I have an appointment for the School of Liberal Arts. So I get to do a little bit of everything. It's pretty good. That's
great. So have you always been interested in ethics and that sort of issue from the get-go, or is that a later development in your career?
I think I've always been interested. I think when I think back on myself, from my earliest days, I think I was interested in ethics and how it would apply to the work. I think most of us who practice medicine at some stage in our career decide that we're able ethicists just by virtue of experience. For me, I think that several years ago, I thought, well, maybe I need a little bit more. And so I did something that was a bit unusual. I went back to school, and I went and I got a master's in bioethics at Emory, where I am. And when I first went in there, I thought, the academy has nothing really to teach me. I'll just be here and I'll just really be schooling them. But, that, of course, was incorrect. And I felt and found that the academy was really quite a valuable experience for me. I think some ethical concepts really are better workshopped in the academy. And sometimes the bedside or the street, as you will, can create an intensity that may lead you to where you may not intend to be. So I think both anyway are valuable. So for me, that was a very positive experience.
That's great. I took it wasn't a master's but I took a sort of a course in bioethics, a year long. It was remote learning, and it was helpful. At the same time, I think a couple of years when we launched the podcast back in 2018, we had a guest on our show. I don't know if you've heard of a man named Tom Koch.
I don't think so.
So he's a Canadian. He's kind of a jack of all trades, but he's an ethicist, and he wrote about bioethics, and he wrote a book called Thieves of Virtue, and that was he applied that to bioethicists, or to bioethics in general. I don't think he was trying to get personal against bioethicists, but he was commenting on the separation of ethics from medicine and how medicine has become essentially a technical endeavor. And all the ethical considerations are left to the philosophers, who then tell us what to do. And he laments that fact, and I think he's correct. So, I mean, medicine is intrinsically kind of an ethical behavior. There are moral issues that bear on how we practice all the time.
Well, I actually would say that everything that we do, every decision we make, every action is ethical. And so this idea, I think it's to suggest somehow that ethics is somehow separate or apart from medical practice. This already is the problem. I also think that ethics in medical school is still, frankly, fairly poorly taught. I don't think most physicians understand about ethical adjudication or recognize it as particularly valuable. I know hospitals JACO requires an ethics committee, although what that ethics committee does or its deliverables, can be very meager. So I agree with you that physicians should very much be at the table with the other ethicists, if you will, and that we have something very important to add, and we should not give it away to others.
Mm-hmm.
But I do think that there is value in the classical training. And so for me, I needed to do the classical training. So I went back, I said, to school. I went to classes. I wrote papers. I wrote a thesis. I defended it. I needed to do all of these things, I think, to have my proper bona fides and not just my experience as my guide.
Excellent. So Joel, I think you, correct me if I'm wrong, but did you first start get interested in the role of physicians in capital punishment during executions? And I mean, was that one sort of practical application of your work in ethics, or how did that come about?
Sure. I mean, like I've learned to say, or what I say currently, is that ethics, first of all, is a blood sport. Okay, and so if it stays in the academy, it is not, I think, living up to its potential. Mm-hmm. And so it's important to take what one knows and apply it. And so for me, actually, it began somewhat serendipitously. In my practice as an anesthesiologist, I began, and others as well, noticed that certain kinds of medications were disappearing from the market. And one specific medication was sodium thiopental. And I thought, sodium thiopental, I used it all the time as an induction agent in anesthesia. And I thought, well, did we forget how to make it? Like, why did it disappear? And I began to search for an explanation. I actually planned a conference at the time that was called On the Ethics of Drug Shortages, thinking that this was going to be a story about rationing, which I thought, well, I'll just accept that it's gone. But my investigation led me to an unusual place, which was capital punishment. I learned that sodium thiopental, which I had used, in anesthesiology, was being used now in execution. And the story that's told, which might be apocryphal, to be frank, but the story that is told is that sodium thiopental was being manufactured by a single company called Hospira, which is an American company. The company is no longer in existence, but at the time, Hospira was manufacturing sodium thiopental in Italy. And as Italy is part of the EU, there is a prohibition on any European country that is a member of the EU to make a product that ends up in capital punishment. Capital punishment is not present in the EU. And so the company was approached and said, listen, your sodium thiopental we think is ending up in execution. Can you guarantee that that won't happen? And the company said, we can't guarantee it, so we're just going to stop making it. And so sodium thiopental disappeared. Now, when I learned of this, I was frankly outraged, because I thought, how is it that medicine, which has a very specific kind of indication for treatment, is being usurped and now being repurposed as poison? And so I wrote a piece, an opinion piece, just like that. And I wrote about this, about how I felt that my practice was being invaded and overtaken by others, and I was opposed to it. And I said something like, and the piece was published in USA Today, and it was something at the end, I can't remember exactly, but it was something like, if the state wants to execute people, they're going to have to bring back the firing squad, the noose, or something like this. And after that, my phone started ringing, and I started getting phone calls from attorneys who said, "Oh, I read your piece, and would you be willing to, work on defense of death penalty cases from your perspective on your concerns about lethal injection?" And so I said, yes, I think so. Having really no experience in any of this, I'm not a person that has had much of a background in criminal justice. I'd never been to prison before. I can say now I've actually been to death row in 6 states, and I've witnessed an execution. And I've now done dozens and dozens of these cases, and my position has not changed. which is
So,
that.
go ahead. Yeah, I wanted to clarify whether you're against capital punishment on principle or against the physicians being involved in capital punishment.
Well, so look, this is a question that I'm asked, and I'm going to give you my standard answer, and you can believe it or not. And my answer is that when it comes to the rightness or wrongness of capital punishment, I'm agnostic. And when it comes to the use of medicine as an arm of state power, I'm absolutely, unequivocally against it. And so I think that if capital punishment should one day eliminate lethal injection, then I would I guess I would have to reevaluate my involvement here. I think that, capital punishment is one of these kinds of issues that's so polarizing that as soon as people decide that they've got your number, that you're either for or against, that's kind of the camp that you're placed in. And so I say this with sincerity, that I'm here to talk about medicine. And yes, the other subjects are important, and I'm alive to the fact that that someone has been killed, someone has been murdered, and that lives have been changed. And I'm not here to try to. I confine my attention here to what I think are the technical aspects of execution, where I think a doctor can opine.
Okay, so how was your testimony helpful to the defense if you're agnostic about capital punishment?
Well, so the thing that will be odd for people who are not experienced with this to learn is that in order for execution to be lawful, it has to take a certain form, and the form that it must take is generally the legal point of this turns on the Eighth Amendment, which specifies that punishment cannot be cruel nor unusual. Now, we can set aside the unusual part and focus on the cruelty. And so it comes down to the question as to whether or not punishment by lethal injection is cruel. And so the arguments are basically twofold. The question is to whether or not execution by lethal injection is cruel for a particular individual, so that is called an as-applied challenge, or the other kind of challenge that sometimes is brought against lethal injection is called a facial challenge, which means on its face that lethal injection in anybody would be cruel. So it becomes, so here, my argument has been that lethal injection is cruel. I think both, particularly in certain individuals who may have coexisting medical conditions, or increasingly by the method itself. And so my view on this is somewhat changed. In the beginning, I thought, well, lethal injection might be cruel in an as-applied challenge because of coexisting medical conditions. Most people who are on death row have been there for decades and their health is poor. But it turns out that also by kind of serendipity, I made another discovery that now makes me feel quite certain that lethal injection is always cruel for everyone by design because of the way that it's done.
Well, we'll get into this, but just, I mean, for somebody hearing you right now, it may seem kind of a paradoxical, because wasn't lethal injection meant to be to ease the pain of the electric chair, or I mean to avoid? I mean, wasn't it by design supposed to be a more humane, if we can put that word to it?
Well, okay, so let's talk about humane for a second, because I think humane is interesting because people use this word. Now, execution, interestingly, does not have to be humane. I actually don't know what that means, apart from it meaning, I don't know, human-like. And we know we have a common meaning where we think it means to be kind or something. But it's interesting because when we say the expression, I was only human, we usually offer that when we've done something terrible. So I don't quite know what humane means, but the law does not ask for humaneness. And I've also written in the past that I've said that the absence of cruelty is not the presence of humaneness. Let's be clear, we're not talking about a kindness or that we're trying to make execution something that isn't even painful, but it can't be cruel. And cruelty is a very particular kind of idea here, although difficult to characterize. And the problem too is that you can't ask an executed person. The law turns, of course, on the cruelty of the person being punished, in this case, executed. But an executed person, of course, cannot say afterwards how they experienced their own death. I imagine they'd all say it was cruel. So it becomes a story about observers, about witnesses. So that's the problem here.
Isn't there a dimension of, I mean, doesn't the intention of the executioner matter? I mean, when you talk about cruelty,
yeah,
well, I mean, when I think about it, you think cruelty means that you want to, the person wants to inflict pain or suffering.
Right. You see, now, like I think that the court has become cruel. And the reason why I think the court is cruel is because it knows. To your point, it's one thing if you do something and it turns out to cause pain and you didn't know it. I suppose you could be excused in a sense. That's not the same thing as being cruel. I mean, doctors also inflict pain on patients, constantly. Now, our state of mind is not to be cruel, but if you know that something is going to hurt and you do it in that way, in this case, punishment, where you know it's going to cause a certain kind of death and you do it anyway, well, to my mind, that's the definition of cruelty.
Mm-hmm. So what is it that you discovered about the lethal injection that people didn't know?
So, I would go to court and I would always lose every time. And I would say this inmate is suffering and because they have heart disease or because they have lung disease or because something else. And I think I'm seeing something here that would occur, based upon what I think would be the interaction of the technique of injection and the health of the inmate. And they would say, oh, well, it's brief, or when we watch it, we don't see anything. Lethal injection by design is quite a bloodless affair. It's pretty banal when you watch it. But I just thought that there was something that I was missing. And I was given a document that contained within it a series of autopsies of inmates that had been executed. And the question that I was asked was to look at the blood levels of, in this case, it was sodium thiopental or pentobarbital. And I was asked to comment on whether the post-mortem blood levels would correspond with a toxic amount that would cause death. Now, that turns out to be more complicated anyway, but what I was given, not only was I given that information, but I was given autopsies, the complete autopsies of all the, the visceral organs. So I began to just look at these autopsies. And what struck me immediately was a surprising finding, which was most of these inmates, more than 3/4 of them, had heavy lungs and twice the normal weight, and lungs full of fluid and fluid in the trachea, pulmonary edema. And I thought, well, how did that happen? I mean, it wouldn't happen after death, because after death, of course, there's no circulation. So there would be no pumping of blood and there would be nothing of that sort. And if death was instantaneous, then there would also be no pulmonary edema. It wouldn't be like that. Like, I think people thought, well, lethal injection was something akin to falling asleep, and then you would die, and then that would be that. The body would be pristine if that was what was happening. So it occurred to me that something else was happening here, and that in fact these inmates, and also I should say, the pulmonary edema could not have been there before the execution began, because if all these inmates were in pulmonary edema, I guess the first question would be, why would they all be in pulmonary edema? And if they're in pulmonary edema, we would know they couldn't lie flat, they'd be very uncomfortable. So none of that was being reported. So it was clear that pulmonary edema was commonly occurring in lethal injection in most inmates by as yet an uncharacterized mechanism. And we know that pulmonary edema is painful. That pulmonary edema is uncomfortable. It's terrifying.
Right.
So that's what I discovered, this finding.
Before we go further, can you give us, I mean, is lethal injection standardized across the US? Is it the same method, the same cocktail, or is it
It's actually different in every place constantly.
Okay.
And not only that, but many of the states that use lethal injection have laws that create secrecy around the procedure itself. And so it's against the law to even inquire about what exactly they're doing. I've been given lethal injection protocols, and I even hate to use the term because I think that these are terms of art: protocol, experiment, technique, all these things, even all the words that are used, of the components, a gurney or an injection. But so none of this is medicine, none of this is science. But I've been given these documents, and they're redacted from top to bottom. Okay, there's I can see nothing. I can see that it's the Department of Corrections of State X, but all the details are redacted and based upon secrecy legislation or something akin to that.
That's amazing, because my impression was that there would be some sort of historical record, even maybe publication. The way the guillotine was invented, it was sort of in the open. Allegedly for similar reasons, right? To be less cruel to the I don't know
No, you're right about that. The guillotine was invented to be an efficient form of killing, and perception even then was that execution should be cruel. This is the stuff of Michel Foucault and the idea of the evolution of punishment. We began with punishment as drawing and quartering. And we've now, evolved into something different, although the element of control remains. That's the common, I think, element that has never gone away from punishment. But execution, and this also may be shocking to people, but execution in this country is meant to be observed. It needs to be observed because it had only been through the witnesses, the observers, to be able to engage their empathy to decide what it is that they were seeing and if they were seeing something that was cruel. Because again, you couldn't ask the inmate because now they're dead. So the witnesses become critical in what they think is happening, and what we think is cruel, of course, evolves, as our society evolves.
Okay, so it must have been the case that states, prison systems hired physicians, presumably. Maybe, I don't know, they may have hired vets or whatnot to develop those protocols.
Well, it's complex because now professional societies and state medical boards generally are against the use of medicine and physicians. So how do you litigate it? So it turns out that, of course, we can talk about a medical board. So a medical board, of course, exists as usually through a Medical Practice Act, through a statute by a legislature. And so the legislature says, we don't know anything about doctors, but we're going to empower this group still that must answer to the legislature and answer to the governor. And this is what we want you to do, which all goes well and fine until the governor decides that I need you doctors to do something for me. I need your expertise. And I'm going to pass a law that allows this. So if the state medical board says, well, we don't want our doctors to do that, or if a professional society, says we don't want our doctors to do that, we think it's not what a doctor does, the state can say, well, this is lawful in our state. And so it turns out that the chief physician of a state is not the medical board, but the governor. So when the governor decides that doctors can act a certain sort of way, the law supports that. So I think it's, lethal injection is so good an imitation of a medical act that it fools doctors too. They think that they're practicing medicine, some of them, in a way that, clearly they are not, but it may feel like that to them, and may think, oh, the inmate is a patient and I'm merely reducing suffering. That's an argument that I've heard before. I think it's a weak argument, but that's an argument that I've heard before.
Do you know, was there any published theory in support of lethal injection that it may, and that one would die, maybe by respiratory suppression, or, what was the...
It was just never, it's never been, maybe this is a time to bring in a discussion a little bit about assisted dying, because it's the same kind of problem here, that in neither of these cases was there any kind of examination, of investigation of the claim. The claim was, outwardly it looks a certain sort of way, so inwardly it must be so.
Right.
And I've always been interested in the inward, but the
So,
inward experience is difficult to evaluate, and it certainly has never been evaluated, only by people watching.
right. So tell us about that experience that you had witnessing a lethal injection and execution.
So the name of the inmate that was executed was named Marcus Wellens. And let me also I want to just say that, because I don't want people to think that I'm not alive to the fact, again, that someone has killed someone, someone has murdered someone, and that lives have been changed. I'm not an apologist, I think, in that way. I also think that, that we must test justice on the people we despise, because otherwise no one is safe. And in the same way, as a physician, I like to say that the kind of patient I like the most are the ones I like the least as people, because then I feel like the work is pure. We do these things because it's principle based, and that whether or not the inmate is a good person or a bad person is frankly not material. They're owed a certain kind of level of justice. So Marcus Wellens, was a client, by an attorney, and I was hired to be an expert and give my opinion, not to comment on what he did, but to comment on the technique of execution. So Marcus Wellens, his attempt to have his execution set aside had failed, and so he was set to be executed, and he invited me. And I went to the execution. It was a very strange experience. And first of all, like, it's many, many hours, and you're kind of in prison yourself while you're waiting, and you're taken, and they take your phone away, and your watch away, and pens and nothing, your identification. Like, it's a very odd experience. So finally, the time comes, and there I am now, sitting with the others. It's sort of set up almost like church pews, and there's a glass, and there's Marcus Wellens behind. He's covered from head to toe. His arms are restrained. His fingers are taped to the arm boards, which was interesting. I could see a couple of intravenous's. But the room also was soundproof, and so I think the warden was in the room. Asked Marcus Wellens to make a statement. He made a statement. Then the speaker was turned off, so now there was just silence. And they don't say, 1, 2, 3, go. Okay, you don't know when it's even going to start. And so I'm sitting there looking, and there he's lying there thinking, well, when is it going to start? And how do I know? I'm trying to see if I can see something. So I have no watch, I have no way of keeping time. So I just start to count seconds, thinking maybe I'll just start to count now in my head and see if I can kind of think what I see. So I see some kind of twitching, some sort of movement. And then in this particular case, suddenly, one of the there's a corrections officer in the standing next to him, who falls, legs locked. He falls onto the legs of Marcus Wellens, just collapses. And suddenly the room, there's pandemonium. It's all silent, because you can't hear anything. And the room fills with people. People come running into the room, and they pull him out, and they replace him with a new corrections officer. Now, at this point, of course, I don't know what's happening anymore. How much time has gone by? I've missed the whole thing. And that's, and at some point, someone walks in and says, he's died. A doctor in a lab coat and with a stethoscope. And I think, what's the lab coat for? What are you playing at? And by the way, when there was an actual patient in that room who was the corrections officer, I didn't see you running in here. Like, that's your duty. So now you're playing at something else. And the state, by the way, when they reported the execution, they did not report that part. They did not report that the corrections officer had collapsed like that, and that didn't make it into the final report. So that was the execution that I saw.
You mentioned something about the fingers being taped, and
yes,
and I think I've read your explanation about what that's about. But
well, I think so. There was an execution in Ohio by an individual named Dennis McGuire. He was executed, and McGuire was executed primarily with opioids, which was a very problematic kind of way of killing him. And what was noticed in Maguire is that he did something where he made a fist, and much was made of his hand gesture. Did it have some meaning? Was he trying to say something with his fist? And so my theory is that the state wants no hand signals, no gestures. And so they're going to tape the fingers down, which they've done. So there's just no way that you can make a fist. Mm-hmm. That's the only, because obviously there's no other reason to do it. It's mm-hmm. just theatrical, to prevent maybe what the state would believe would be a theatrical display.
So if I understand you correctly, your theory is that many of these executions, the mechanism of the lethal mechanism is pulmonary edema, asphyxiation, essentially, fluids building up in the lungs and people dying from asphyxiation. Now, does that mean? I guess an obvious response would be, well, they're unconscious. Why does it matter? What is the mechanism of?
Look, sure. I guess I don't know. Like, what we don't know is the mental state, and we don't know how much discomfort, what kind of sense of awareness they should have. We know that they are, they're alive enough that their circulation and their lungs are filling with fluid. We have seen, many times inmates coughing and moving and struggling. So it's not that they are simply lying perfectly still, unless, of course, they're paralyzed. Then they're lying perfectly still, because mm-hmm. some executions, of course, include a paralytic. But there is some movement there. So I don't know. I think that the movement is potentially meaningful. And since there's no way of actually measuring the internal experience of what's happening, there's no monitoring. This is just, again, a claim. So the claim is by the state that we've got this figured out, that what we give creates a kind of, unconsciousness or lack of awareness. We guarantee it every time. And that anything else that happens after that is moot. Mm-hmm.
During surgeries, of course, that is what we tell patients, right? We tell patients that, we do, how many thousands and thousands of surgeries a day under anesthesia. I know it's become it's of course become very political in terms of, not political, it's become very contentious, the drugs that are allowed to be used, the participation of the medical community. Do you believe that if the medical community was allowed in the way anesthesiologists are allowed into an operating room to anesthetize a patient while a surgeon may crack open a chest, do heart surgery, do brain surgery, do all the different things that happen in operating rooms, do you really think that there's a doubt about being able to suppress the conscious?
Well, sure. Okay. Well, let me answer your question. This is a very important question, fundamental. So here's my answer. I'm an anesthesiologist. Okay. So I know that I cannot actually 100% promise that there will not be some interior experience that people will have. And in fact, I warn them of that before the anesthetic. And then, and also I'm there monitoring it, and with not only one medication or one monitor, but several. I've got backups, I check, I'm doing these things. And then afterwards, I ask them in the recovery room if, depending upon if they're now, the anesthetic has been allowed to lapse and I'm now talking to them. And I ask them what they recall, do you recall anything? And sometimes patients have told me that they do recall things, that they do, where I couldn't really notice it. We call this awareness. This is a thing we know in anesthesia. Now, I reassure them that they were safe, because here they are safe. And even when I say to people that sometimes you may have some memory or an experience, but rest assured, we are watching you and we're taking care of you and you're safe. So this is not at all the same thing as what's happening in execution. There's no guarantee. There's no, discussion after the fact. There's no monitoring, nor should there be, because again, if you look at the package insert for pentobarbital or midazolam, there's nothing in there about execution, and there's nothing in about in the medical practice about assisting punishment or execution. That's not our
I think that's
job.
a separate. Yeah, no, that's a fair point, and I think that's a great point to, I think, argue whether or not societies should proceed with capital punishment or not, because it does seem like medical sciences, medicine, if you want to have a patient be unconscious to be able to do something to them, I'm using the word patient, if you want a person to be unconscious in order to be able to do something to them, you have to have full involvement of the medical community, and perhaps that's beyond the ethical pale, and that's something to argue. But we certainly, press forward with surgery, and the vast majority of patients and doctors and surgeons, et cetera, and anesthesiologists, with all the monitoring and whatnot that they have at their beck and call, with a fairly high degree of certainty, there's an assurance that you're going to be able to make it through this, and it's not going to be a horrendous, horrible experience where you can feel a sawbone kind of cracking through your chest, and kind of going through that whole thing.
Yeah.
But that would be a separate question. But you're making the argument that we'd be unable to provide that, though medically speaking, if we say moved an operating room into an executioner's room, we could provide that same high degree of certainty that we will be able to suppress the conscious of the patient so someone else can do something to the patient.
Well,
is that a fair assessment?
Well, I think, again, let's talk. So you're saying that an inmate is a patient.
Right. I'm using that. I shouldn't be using. Yeah, I should be using the word patient, because this isn't certainly. Yeah.
But this is, you see, this is the problem. Yeah. Is that that remember that as a doctor, I have a contract.
Right.
With an individual who is my patient, either by dint of them consenting or by other things. Like, for example, if a person is in an accident or something and they're brought into the hospital, then there's an understanding that I'm going to act, in an assumption about a doctor-patient relationship.
Right.
But remember that I can only touch someone if they give me their consent and we're in a doctor-patient relationship. Otherwise, I have no claim, I have no role. So,
but you're absolutely right. But I think that's a separate issue. I mean, I think part of the problem is that society has decided that and again, that it's a battle to fight, but society has decided now for some time, and some have abolished this for a variety of reasons that include what we're discussing. But nonetheless, there are, Western developed, not just Western, there are developed societies across the world that have decided that there are certain crimes that cross some line that, we need to execute folks that have committed crimes over a certain thing, over a certain line. So then the question becomes, okay, what is the most humane way to do that? And my concern is that if we put up blocks to that, we're kind of circumventing what society wants by saying, no, we don't want to be involved. You can't use Versed because Versed has not been technically indicated for that, and who's going to ever do a trial, and is the FDA ever going to approve that for execution? I mean, of course, the pressure on these drug companies is enough that they don't even want to have their drugs be used for this. So, but then what ends up happening? What ends up happening is society still wants to execute these folks. And then if you have non-medical personnel that are trying to put IVs in, guess what's going to happen? You're going to get IVs in that are infiltrated. If you have non-medical folks that are going to be attempting to suppress the conscious of folks, then you're going to clearly have a whole setup that is not nearly as good as what you're doing in the operating room. So it's almost like if we want to draw this line and say, okay, we are not going to be involved here because of what we're talking about, but society still goes on and proceeds with what they want to do. we may end up in a place where it's worse for folks. So you're saying that a lot of patients are gasping, there's some of them are writhing, etc.
Oh, wait, now
It's,
again, you said patient, okay?
yeah,
And
I
you
keep,
should have said
yeah,
inmate, okay?
right,
Because I think
right,
that, like, let's be clear that I think that the House of Medicine, we're not combatants, okay? We're non-combatants here as doctors.
right,
Medicine is not meant to be part of the arm of punishment. Like, that's how I began. And I
right,
think that even when you say humane, punishment by law does not have to be humane. It just can't be cruel. That's what the law turns on. Society may choose to have capital punishment. That's
okay.
that's the society's choice, but that doesn't necessarily involve a doctor. And even to suggest that a doctor can say, well, because I know what I do in the operating room, I can now do that in the execution chamber. I think that's a false claim. I think that that's not true. And if the state
But that's
wants
false. It's false because,
it's unverifiable, it's uninvestigated, it's just a claim. And that
but we
also,
would never use that language in the operating room, right? We would never say it's unverifiable
no,
that we
because
in
an
the operating
anesthetic,
room.
no, because an anesthetic is not an execution, and because there's many, what we know about anesthetics cannot be lifted onto executions. They're not the same thing. And the state doesn't need us. If the state wants to kill people, that's the state. It's not the state doesn't know how. It's trying, like, it's using us on purpose, because what it's saying is, you guys, like, you've got this kind of reputation of safety, of oversight, of comfort. Like, why not shoot people? Okay. Because guns are what? Guns are for
Yeah,
defense, I guess.
yeah,
They're not meant to be for shooting people. Like, you don't need us. Like, not only do they want what we do, they want us, because they want our endorsement. They want our presence. They want our lab coats. They want the kind of sense that, don't worry, folks, we've
right,
got, medicine here. And that's what's so sinister about this, is that,
right.
and that they've
I find
fooled
that,
us.
yeah, I
So
find that to be a
just to be clear,
powerful argument.
sorry, but just to be clear, Joel. So what you're saying is that what's done in the operating room, I mean, we never kill people with anesthesia in the operating room, and therefore we don't have any way of understanding what that experience is, or I mean, at least that's part of the argument, isn't there? I mean,
Well,
that
look,
we don't push the anesthetics to the point that we know
yeah,
that
sure. Like, some doctors would disagree with me, but my position is that, killing is not a treatment. Okay. If killing was a treatment, I guess we could be using it all the time. We'd all be less busy.
Right.
But I think that killing is not a treatment. So I think that reducing suffering, that's a treatment. That controlling symptoms, that's a treatment. But killing, like specifically killing, I think that's not a treatment. That's something different. And we're not expert in that.
Right. So if society has decided that we need to that there are certain crimes that that the penalty must be death, is shooting some? Do we then get involved with, is the guillotine humane? Is shooting somebody humane, or is that the wrong word? Or
remember, humane is not the word.
or is it cruel?
Well, cruelty, I mean, yeah, we could probably unpack whether it's cruel or not, but remember that too, that, like, it's not my responsibility to figure out how to execute people. That's just not my job as a doctor. As a citizen, I might have some views about that one way or the other, but when I am practicing medicine, I can't take what I know there and lift it onto that and claim that there's some sort of mandate, because there isn't. So just because the state, and I'm not alone in this. I mean, I think the American Medical Association, the American Board of Anesthesiology, these organizations have been very clear, saying that that's not the doctor's job.
Right, but if the state then, I mean, if the state then has a separate group of folks that are not within the practice of medicine, but they can administer the same drugs we administer, then they can do that.
If they will, it depends. I mean, if they choose, okay, the state can create, I suppose, executioners. Like, that would not be the first time. But then the state still has to prove that what it's doing is not cruel. And this is where I think that lethal injection, is by design, is cruel because of what it does.
But the point you make about pulmonary edema, these are, as I understand it, you ultimately are injecting patients with drugs to stop the heart, correct? That's how ultimately you're
Sometimes,
Is that
not always, not always. Sometimes
okay?
it's just pentobarbital. So no,
Oh, it's just
pentobarbital
pentobarbital.
is,
Okay.
it's kind of a promiscuous molecule. It does a lot of things.
Okay.
But sometimes there's potassium, sometimes there's not. Sometimes
Okay.
there's a paralytic, sometimes there's not. Sometimes, like the execution recently in Oklahoma that you may have heard about, where it was a combination of midazolam followed by potassium, followed by vecuronium bromide, a paralytic, and then potassium. So
Right.
that was a horrendous execution, not surprisingly, because midazolam is problematic in this way. So I think that.
But when you do stop the heart, and I mean, is it do you not? I mean, there's likely to be when the heart there's likely is to be. I mean, I don't see how you don't have. I mean, I assume you would have pulmonary edema if you're
You
stopping the
wouldn't.
heart.
No, when the
No.
heart is stopped, the heart is stopped, and there's no more. You have to have circulation to create pulmonary edema. Like it doesn't just if someone is killed instantaneously, okay, something like there's no pulmonary edema. That's not what it's.
Instantaneously, yeah.
Yeah, there's
Right.
nothing
But
like that. So there has to be this kind of period.
right. But when you're stopping the heart, there's some. Yeah, right. Sorry, but when you stop
Well,
the heart, even with
yeah.
KCL, right, or what have you, there is some period of
Yeah, but
torsades or
not.
VT/VF. So there's some period of time before the heart is just. It's not standstill heart stop, right?
Well,
Meaning that's what happens with.
I mean, well, here's what I think. Maybe I should just tell you why I think what is happening, because it was not
Okay.
clear to me why it was happening. I'm still not certain, but I have an explanation. So midazolam, for example, is suspended in hydrochloric acid. It's a molecule that when it enters the bloodstream and the pH changes, it then comes out of solution and becomes effective. But to be injected, it has to be suspended in an acidic solution. Now, when you give a small amount of midazolam, or a working clinical amount, say 5 milligrams of midazolam, the amount of acid that you're giving there is really pretty minuscule, and the body's normal buffering system just manages it fine. But the state, instead of giving 5 milligrams of midazolam, gives 500 milligrams of midazolam. So they give 100 times more midazolam. And all that midazolam, again, is suspended in hydrochloric acid. So I actually think it's not the midazolam, it's the hydrochloric acid that's causing the problem. So now you're injecting hydrochloric acid into the bloodstream of someone. It enters the lungs. The lungs are destroyed and begin to leak, and that's the problem. And pentobarbital, by the way, is a strong base. So it's the same thing with the alkali solution of pentobarbital. That's my speculation. But now, and that's why I think because the drug itself, like benzodiazepines, shouldn't do this. So why do they do it?
It's possible.
Let me ask you a little bit. I don't know if you have any experience, but one ethical issue that I'm particularly interested in is brain death, the concept of brain death.
Yes.
Have you ever been an anesthesiologist involved in a harvesting of organs?
Oh, sure.
So, right. I mean, the claim, even to this day, nobody believes it, but the claim, and at least legally on paper, is that brain dead patients are cadavers, right? That they're actually dead. Yet, of course, I mean, I think it was observed quite early on that when you do the harvesting of organs, there's an immense surge of adrenaline, where the blood pressure goes up very high, and there's tachycardia and whatnot. And that's when anesthesia was sort of brought in to sort of minimize that. What's your experience with this? Is there I'm looking at the decoupling between the bodily response versus the question of consciousness and experience of what is going on.
I think that the only reason why brain death exists as a designation is for specifically so organs can be harvested.
Mm-hmm. I agree.
I have patients, in the ICU that have severe brain injury, and they don't have to be brain dead for a family to think, well, we're going to stop. So we don't need to say that they're brain dead for them to stop. We recognize that brain injury can be sufficient, but brain death is needed. So, and this is the dead donor rule that you may be familiar with, so now we have to create, first of all, this thing that we call brain death that is arguably, debatable.
Illegal fiction.
And so it's a legal requirement, and it's a kind of a legal fiction, because I think that we don't always know. Now, is there a greater good? I don't know. I think that, one way looking at this ethically, I suppose, one could imagine some kind of consequentialist or utilitarian way of looking at this and saying, there's a greater benefit. And even if these people are not completely brain dead and there's some kind of very low level of brain activity, well, what's the harm and how could it possibly ever be, and so on. I mean, I don't know. It's a big problem.
No, it is, and I don't want to sort of open a whole different discussion here, but my point is that we can find signs where the body is in very, very high distress, despite presumably awareness not being to the extent that we at least responsiveness not being present. And that's one that I have in mind where there's no responsiveness. And of course, there also have been many different cases where, outwardly there's no response. And I think, you alluded to that, but patients after the fact, in different circumstances, different situations, can recover and then relate that they've clearly have experienced, being present under certain circumstances where.
I mean, I think that, these are like, if you think about in one category, people who are, former people, since we can't call people who are alive or who are dead people, they're now former people who are brain dead or dead, inmates who are killed, by the state, people who die, of other reasons, say, as our patients. These are all different sorts of kinds of situations. And what we do the best we can. And we work within our mandate. We work within the confines of our profession. And I think, what we always have to guard against is the fact that doctors, have become the arm of the state power in ways that I would, take exception to.
Yep. No,
I
absolutely.
think we must guard against, we must guard because we know powerful things, So can a doctor impersonate themselves? Can they say, well, look, I know these things, but here now, I'm not practicing medicine, okay? I'm just a guy that knows these things. So I'm just a guy that has knowledge, okay? But don't think of me as a doctor. Well, we can't, take off that skin. Once it's on you, that's you forever. Maybe you may, even if you retire, you still know it.
Yeah, but I think as you mentioned, the point of bringing doctors in is precisely to legitimize, to sort of endorse the practice, and that brings us to the question of assisted suicide. That you wrote about also recently, making that little connection between where we have doctors involved in a certain procedure that leads to death by design, by intention. And so tell us a little bit about how you view the connection between lethal injection for executions versus legal administration of legal drugs for suicide.
Well, in the Canadian system, I can speak, the Canadian system uses an injection combination that is almost identical to lethal injection. They use a paralytic, they use a barbiturate, they'll use sometimes benzodiazepines. Like they actually strikingly mimic unapologetically lethal injection. And the paralytic is particularly irksome to me. And I've said to people who do this in Canada, like, what's that for? Why are you paralyzing people when you're killing them? And they say, well, it's about dignity or something. And I think, well, what? Like, it's not dignified to whose dignity? So now you're talking about curating something to be observed. So, because you don't care about the inner experience. Now you're just saying, well, for the relatives or the families or for us, we don't want to watch someone breathe hard or something. And but I was invited by the Senate of Canada, who was reviewing legislation, Bill C7 was the bill, to talk about execution, or rather talk about assisted dying, to expand it so it would be more available to other people. And I said, well, okay, my concern here is that my experience with lethal injection tells me that, that inmates are getting pulmonary edema. And now you're giving the same thing to people that you're saying that you're killing them as an act of kindness, as some that they desired this. And are you being honest? First of all, do you know exactly what you're doing? And have you told the public that, by the way, just so you know, there's a chance, a reasonable chance, that you will actually have pulmonary edema before you die. Now, people may say, that's fine. I don't care, because I'm living this life of interminable suffering, and I'll subject myself to further suffering to get there. But that's not what's happening. It's not, when I talk to people about this, they shut me down and they say, well, look, we know this is right because we've seen it. Our eyes have told us, but you're not really investigating it, and you're paralyzing these people. So if you think that looks great, I guess it does, because you're paralyzing them. So let's just be honest. Let's just say what this is. Let's look at this and decide, how are we killing people? What's the experience that they're having? And if people knowing that choose it, that's a different matter.
I agree with you. I mean, to me, it's this game that we play that's most irksome. This masquerade. Do you think? I mean, I'm against assisted suicide, even if it was, perfectly peaceful, sort of a blissful kind of a psychedelic experience of nirvana. And likewise, I think my position on lethal injection, capital punishment, is a little bit like yours. I mean, I'm kind of agnostic still. I'm not fundamentally, in principle, against capital punishment, but I'm certainly against, this pretense that, bringing in the medical profession into it, and the pretense that we can make it sort of painless, when we're treating ourselves, right? I mean, we're not treating the inmate. We're just treating our own emotions and our own response to these situations. Do you think is it a little distracting to emphasize what you're talking about, this experience? I mean, Anish doesn't seem super convinced that there's a problem, and then somebody could say, well, listen, we can do it better. We can really make sure we can do animal studies. We can do this. We can do that, and make sure that it's not so unpleasant.
Well, I mean, I think it'd be arguable that you couldn't do animal studies. That would be unethical. I think to execute animals, I think would be pretty that would be something I don't think you could do.
I don't know with what's going on right now in North Africa.
So, you
sponsored by the NIH.
Maybe
knows,
you
right,
can't do a prospective trial on execution for humans. There's no way to do it. I do think whether or not the problem is, I think, like, maybe to both of your points about, do we want capital punishment or don't we? I think that the problem of lethal injection is actually set the debate backwards, not forwards, because by sanitizing, the experience of killing someone, we still don't really know if we want it or we don't. Like it's easy enough for a Supreme Court justice sitting there in their black robe to go like thumbs down, but like I've been to death row, okay? I've been there. So my view on this is different. And I'm not trying to say that you have to have the experience to know it. But I think that from the public's perspective, because this is becomes so sanitized, we lose the sight of the fact that we're actually killing someone. Right. Now, again, maybe we want to, maybe we don't. But lethal injection is not helping. It's not helping because it's a myth that it's peaceful. And I say, like, let's open it all up, let anyone go. Like, why, even to become a witness to an execution is generally very complicated. It's not easy that anyone can go. Like, let the public, why not record these things? Why do you have to invite me there and say, no pen, no watch, no phone, close one eye? Like, why would you addle me in this way? Let me see it. Record it. We record everything. Why is lethal injection have to be, according to some clerk who writes it on the back of a napkin with a crayon, what they think they heard? Like, it's crazy. Let's let it be seen, and then at least we can decide whether we want it or we don't.
I think there's a desire for it, and it's a strong desire for it. And it's driven by, the judge. You're talking about having a different perspective than you do. The judge, of course, has to answer to the 15-year-old teenager that Marcus Wellen raped and strangled and killed, and so there's these
but
things that have
Anish,
to be,
don't you think that they actually for that, it'd be actually more helpful to have a public execution.
Yeah, no,
in the
but
open
then,
with,
but then I think,
with
but then as
guns
members,
or, you know,
I agree.
as a,
But then
with
as
a firing
members of,
squad.
yeah, no, but as members of society, then we're gonna have to be, or then we're gonna have to say, okay, we have these skills. Dr. Zavat certainly has the skills to anesthetize someone, and then so we as members of society are going to have to be okay in a society which is either taking people and putting them in front of a firing squad. I mean, is it better for Marcus Whelan to die in front of a firing squad,
Well,
or
I
is
mean,
it better for him to die? I mean, I don't. I think we get put in a very difficult position. I think it's fine, make a principled argument to say that you know, we're doctors and we are not here to we're here to treat patients. We're not here to kill inmates. And I think that's a good principled position to take. But
well, then,
I think we're still.
Why would you mention Marcus Wellens and what he did? Like, if you're talking, because I think that you're falling into a trap here. Remember, like, none of us here are experts in criminal justice. So you read what you read in the paper, or you Google it, and you say Marcus Wellens, what did he do? But you don't know the backstory there. So I'm not saying that Marcus Wellens was right or wrong. But all these, remember that execution. But if you listen, like, if you look at this kind of, you know, we try to figure out, like, what's the nature of crime, you know, what happens to people, why does this happen to them? How is the criminal justice system applied? Is it applied fairly, impartially? Is that
the doctor's role?
Well, it absolutely is not. That's why we're talking about. But when you say Marcus Wellens did something, you're now saying, is that the doctor's role also? Like, that's not the doctor's role.
No, but I think, I mean, I think he was putting his faith in.
The judge, I'm saying the judge, you have your perspective because you're sitting at the death row, but the judge has his own perspective because the judge has to preside over, right. So the judge is looking at it from that standpoint, that he's guilty of doing this bad thing.
I'm not saying that the judge is looking at this trivially, okay? But I think that with respect to the way, in my experience, just by being there, I've seen, you know, things that are concerning to me as a citizen now about the way that the criminal justice system unfolds. There's a lot of problem with it. So you might even be for capital punishment, but to say that you're for capital punishment in America, that's a different kind of thing, because capital punishment in America is not well applied.
Yeah, we can have an that's a really good argument to make again, that we should end all capital punishment because we can't be sure that justice is applied well in our legal system. And I think that's a great argument, certainly to make. But that being said, it still doesn't get. So then let's argue. Why are we arguing about whether midazolam and the 500 milligrams in the hydrochloride, whether that'll cause pulmonary edema? Why don't we just make the argument to say that capital punishment is either on principle wrong because we shouldn't end another man's life, or it's wrong because our legal system is so screwed up that we can't be sure that we're actually not killing innocents, which would be a terrible thing. So, but those are really separate arguments to make. The problem is we should make those arguments and we should stop capital punishment because of that. But if we kind of don't make those arguments and then fall back to, well, we can't do this because we can't be involved because it's not within our purview, etc., then what we're going to be left with as citizens, not as doctors, because as doctors, I think we can all agree that we shouldn't, at least the three of us here can agree that we shouldn't be participating in killing people. But we are then going to be left as citizens who have some knowledge of how to perhaps do things in a more non-cruel way. We're going to be watching society kind of end these lives, either by firing squad, by guillotine. Before guillotine, there was, I'm sure we're not going to go back to the wheel, but then what do we do as citizens then? We're going to sit there as citizens and be like, and watch these inmates, some of them may be innocent, except whatever it is, watch them and they have their lives ended by society in ways that are probably more cruel than whether we could be involved or not. So I think does that not present a challenge to you as a citizen? And so, well, what do we do? If not involving ourselves somehow may make things worse for certain people, no?
Well, I mean, I actually think I am involving myself. I'm saying that this shouldn't be done. So
yes.
My conscience is clear, okay, in terms of what I've been doing. And I'm saying that lethal injection doesn't do what you think it does. And so you shouldn't do it anymore. Right. That's my point. And then it's not my job to say you should do it this way or that way. That's not my job. I guess I'll wait to see what you do next. And depending on what you do next, then I may react or I may not react, because it may be that I'm not expert and I can't comment, or it may be that I am expert and I can comment. So I think that is the responsibility, of the doctor, and I've certainly not been silent. I'm all over this. So, I think you make a good point that, it's important to be involved, and to watch these things. But I'm not an expert in killing. I'm an expert in unkilling. Okay. So if you want an expert in killing, then I'd say like you need James Bond or a Newton. Okay.
Right.
You don't need me. Okay.
Right.
You need me to, what I am an expert in is the pharmacology of these particular chemicals that you've chosen to repurpose as poison, okay, and not to use as medicine. So here's my expertise. It's not I'm not a universal expert in all methods of execution. I'm not. But where I think it impacts the doctor, this is where I think I have a mandate, and this is why I act.
All right, excellent.
Joseph, thank you very much. This is a very important conversation to have, and very few people are willing to have it or engage society in it. So thank you for this episode.
Thank you for having me, gentlemen. I very much appreciate the conversation.
Thanks so much.